In 1975, a woman in her late 70s was dying of cancer in a hospital in Cincinnati. She had been diagnosed 8 months earlier. The cancer had spread. There was no treatment that would stop it. Her physicians knew this. Her family knew this. She knew this. And yet she spent the final 3 months of her life in a hospital bed, receiving treatments that could not cure her, in a facility designed for acute care rather than for dying, surrounded by equipment and procedures that were oriented toward extending life rather than toward making the end of it bearable. She died in the hospital. She died in pain that was inadequately managed because the medical culture of the era was uncomfortable with the doses of opiates required to control cancer pain, fearing addiction in a patient who had weeks to live. She died separated from her home, from her familiar surroundings, from the rhythms of ordinary life. She died the way most Americans died in 1975, in an institution, among strangers, in conditions that served the logistical needs of the healthcare system rather than the human needs of the person dying. Her family could not afford the alternative. A private hospice program existed in New Haven, Connecticut, founded by a physician named Sylvia Lack, modeled on the hospice work that Dame Cicely Saunders had pioneered in Britain. It was one of a handful of experimental programs in the country. It was not covered by Medicare. It was not covered by most private insurance. It was accessible only to people who could pay out of pocket for a form of care that the American healthcare system had not yet recognized as legitimate. The Medicare hospice benefit was added to Medicare in 1982, 17 years after Medicare itself was established, as part of the Tax Equity and Fiscal Responsibility Act. It was the first federal coverage for hospice care, and it was the moment at which dying at home, with professional support for pain management and comfort care, became financially accessible to elderly Americans who could not previously afford it. This is the story of what dying looked like in America before hospice care coverage existed. It is the story of the medicine that was applied to dying people because the system had no better answer, of the reformers who built a different model by importing it from Britain and demonstrating that it worked, and of the political battle to convince Medicare that paying for people to die comfortably at home was a legitimate use of federal healthcare dollars. It is also the story of what hospice care has become in the 4 decades since the benefit was established, and of the ongoing tension between the ideals of the hospice movement and the economic and bureaucratic pressures that have shaped the program in practice. To understand what dying looked like in America before 1982, you need to understand what happened to seriously ill people in the American medical system of the mid-20th century, and why that system was organized the way it was. American medicine in the decades after World War II was organized around a model of acute care, diagnosis, treatment, cure. The hospital was the center of this model, the place where the technology of diagnosis and treatment was concentrated, where surgery happened, where antibiotics were administered, where the acute crisis was managed and resolved. The measure of success in this model was cure, or at least stabilization. The patient who left the hospital recovered was a success. The patient who died in the hospital was a failure, or at minimum a case that the system had not been able to win. This model was not simply a commercial choice. It reflected the genuine achievements of 20th century medicine, which had transformed the capacity to treat infectious disease, to perform surgery, to manage acute cardiac events, and to address conditions that had previously been death sentences. The dramatic successes of acute care medicine created a cultural and professional orientation toward treatment and cure that made the management of dying seem like a retreat, a giving up, something that happened when the real medicine had failed. The consequence of this orientation was that dying people were treated the same way that acutely ill people were treated, because the hospital and the physician had no other framework. A patient with terminal cancer received the same aggressive treatment orientation as a patient with a treatable condition, because the physician's training, the hospital's protocols, and the reimbursement system all pointed in the direction of treatment rather than comfort. Physician training in the mid-20th century devoted essentially no time to the management of dying. Medical education focused on diagnosis and treatment, the skills required to support a dying person, to manage pain adequately, to communicate honestly about prognosis, to address the emotional and spiritual dimensions of the end of life, were not part of the curriculum. Physicians who had these skills had generally developed them through experience rather than formal training, and many physicians avoided the emotional intensity of dying patients by focusing on the clinical tasks that their training had prepared them for. The management of pain in dying patients was particularly inadequate. The opiates required to control the pain of terminal cancer, taken in the doses necessary to provide genuine relief, were available but were administered cautiously and often insufficiently because of concerns about addiction and about accelerating death. A dying patient who received adequate pain control might become physically dependent on opiates. Physicians who were trained in the principles of addiction medicine, which emphasized the dangers of opiate dependence, applied those principles to dying patients in ways that prioritized avoiding dependence over providing comfort, even when the patient had weeks or months to live, and addiction was beside the point. The families of dying patients in this system were frequently excluded from the care process in ways that seem extraordinary in retrospect. Hospital visiting hours limited the time family members could spend with dying relatives. Medical decisions were made by physicians with limited input from patients or families. The information provided to patients about their own prognosis was often incomplete, euphemistic, or deliberately withheld on the theory that telling patients they were dying would cause psychological harm. This practice, known as benevolent deception, was widespread in American medicine through the 1960s and into the 1970s. The result was that many dying Americans spent their final weeks and months in hospitals, receiving treatments that their physicians knew would not cure them without being told clearly that they were dying, in conditions that prioritized the management of their disease over the quality of their remaining life. The family was at the margins of this process, visiting during permitted hours, receiving information filtered through a medical culture that was uncomfortable with honest conversations about death and dying. The cost of this system was significant. Hospital care in the final weeks of life is expensive. The treatments administered to dying patients, chemotherapy that could not produce remission, cardiac interventions for patients with terminal illness, ventilator support for patients who could not be weaned from it, were expensive treatments that produced little or no benefit in terms of the patient's comfort or remaining quality of life. The healthcare system was spending large amounts of money on dying patients in ways that served the system's orientation toward treatment rather than the patient's actual needs. The alternative model was being developed simultaneously in Britain and in a small number of American pilot programs. Dame Cicely Saunders was a British physician who had worked as a nurse and a social worker before attending medical school specifically to gain the authority needed to change the medical management of dying. She founded St. Christopher's Hospice in London in 1967, the first institution designed specifically to provide what she called palliative care. Not treatment aimed at cure, but care aimed at comfort, at pain management, at the support of patients and families through the process of dying. Saunders' model was built around several principles that were radical in the context of the mid-20th century medical culture. First, that pain could and should be controlled adequately in dying patients, using opiates in doses sufficient to provide genuine relief rather than the cautious, inadequate doses that the addiction-conscious medical culture preferred. Second, that dying patients should be told the truth about their prognosis, treated as people capable of making decisions about their remaining time rather than as patients to be protected from upsetting information. Third, that the family was part of the unit of care, that the emotional, practical, and spiritual needs of family members were as legitimate as the physical needs of the patient. Fourth, that the goal of care for dying people was the quality of their remaining life, not the extension of its duration. These principles were not entirely new. They were articulated clearly in Saunders' work and in the hospice model she developed, and they provided the intellectual foundation for the hospice movement that spread from Britain to the United States in the late 1960s and early 1970s. The Connecticut Hospice, founded in New Haven in 1974, was the first American hospice program, established by Florence Wald, who had visited St. Christopher's Hospice in London and returned determined to build a similar program in the United States. The Connecticut Hospice provided home-based palliative care to dying patients and their families, with a multidisciplinary team of nurses, physicians, social workers, and volunteers supporting patients who chose to die at home rather than in the hospital. The program worked by the measures that mattered to patients and families. Patients who received hospice care reported better pain control than patients in the hospital. Their family members reported less distress during the dying process. The quality of the dying experience, measured by surveys of patients and families, was significantly better in the hospice setting than in the hospital setting. But the program was expensive to run and was not covered by any insurance. The families who used it either paid out of pocket, which was feasible only for those with significant financial resources, or relied on the Connecticut Hospice's ability to raise charitable contributions to subsidize care for patients who could not pay. The model that worked was not the model that was financially accessible to most dying Americans. The movement to make hospice care financially accessible through Medicare coverage developed through the 1970s, driven by a coalition of hospice advocates, researchers, patient advocates, and eventually some cost-conscious policymakers who saw in hospice care an alternative to the expensive hospitalization that characterized the final weeks of most elderly Americans' lives. The cost argument was important to the political case for Medicare hospice coverage, because the Medicare program in the 1970s was under significant cost pressure and was looking for ways to reduce expenditures. Studies of the Connecticut Hospice and other pilot programs suggested that hospice care cost less than conventional hospital care for the same patients, because it avoided the expensive treatments that the hospital setting encouraged without producing benefits in comfort or quality of life. If hospice care could produce better outcomes for dying patients at lower cost, it was a rare case of a policy that served both the patient's interest and the payer's interest simultaneously. The Congress that added the Medicare hospice benefit in 1982 was a Congress focused on cost reduction, acting under the Reagan administration's pressure to reduce the growth of Medicare spending. The hospice benefit was added as part of the Tax Equity and Fiscal Responsibility Act primarily because it was projected to save money, not because Congress had developed a philosophical commitment to the hospice approach to dying. The benefit was initially a 3-year demonstration program, with the understanding that it would be evaluated and either continued or discontinued based on its cost and quality performance. The structure of the Medicare hospice benefit reflected the tension between the hospice philosophy and the practical requirements of a federal insurance program. To elect the hospice benefit, Medicare patients had to be certified by 2 physicians as having a terminal prognosis of 6 months or less if the disease ran its expected course. They had to agree to forgo curative treatment for the terminal condition, accepting only palliative care. These requirements were designed to ensure that hospice coverage was used for genuinely dying patients rather than as a supplement to aggressive treatment, and to control costs by preventing patients from receiving both curative and palliative care simultaneously. The 6-month prognosis requirement was the most consequential design choice. It was based on the assumption that physicians could accurately predict which patients would die within 6 months, which turned out to be less true in practice than the program's designers assumed. Prognosis in serious illness is uncertain. Patients who are expected to die within 6 months sometimes live longer. Patients who appear to have longer to live sometimes die faster. The requirement created a situation in which physicians were reluctant to refer patients to hospice because they were uncertain about the prognosis, and in which patients were enrolled late, often only in the final days or weeks of life, when the potential benefit of hospice care was most limited. The average length of hospice enrollment in the years immediately after the benefit's establishment was measured in days rather than months. Patients who could have benefited from weeks or months of hospice support were receiving it only in the final period before death. Because the combination of the 6-month requirement, the physician reluctance to certify terminal prognosis, and the patient and family reluctance to accept a terminal designation meant that hospice was being used as a last resort rather than as a planned approach to the final stage of life. This pattern persisted for decades. Studies consistently found that patients were enrolled in hospice far later than optimal, that the median length of hospice enrollment was measured in weeks rather than months, and that the potential quality of life benefits of hospice care were being realized only partially because of the late enrollment. The National Hospice and Palliative Care Organization, which serves as the primary trade association for hospice providers, has documented the late enrollment pattern continuously since the benefit's establishment. The organization has advocated for changes to the benefit structure that would encourage earlier enrollment, including modifications to the 6-month requirement and the foregoing curative treatment requirement that the organization argued were creating barriers to access. Some of these advocacy efforts have produced results. The Affordable Care Act of 2010 authorized a concurrent care demonstration program for pediatric patients, allowing children with terminal diagnoses to receive both curative treatment and hospice care simultaneously. The logic was that requiring pediatric patients and their families to forgo all curative treatment as a condition of hospice enrollment was particularly cruel in cases where the hope of cure, however small, was important to the family's ability to accept the situation. The concurrent care model has been evaluated and found to produce better outcomes than the either-or structure for adult patients as well, but extending it to the adult Medicare population has not occurred, primarily because of cost concerns. Allowing patients to receive both curative treatment and hospice care simultaneously removes the cost-saving feature of the hospice benefit that made it attractive to cost-focused policymakers in 1982. The cost argument that originally motivated the hospice benefit's addition to Medicare has had complex consequences for the program over the 4 decades since its establishment. The benefit was added in part because it was projected to save money. Over time, as hospice became more widely used, and as the providers of hospice care shifted from nonprofit organizations like the Connecticut Hospice to increasingly for-profit providers, the cost dynamics changed. For-profit hospice providers, which now represent the majority of hospice providers in the United States, have been the subject of significant scrutiny regarding their billing practices and the quality of care they provide. Investigations by the Office of Inspector General of the Department of Health and Human Services, by the Government Accountability Office, and by investigative journalists have documented a pattern in which some for-profit hospice providers have enrolled patients who did not meet the 6-month terminal prognosis requirement billed Medicare for care that was not provided or that was inadequate, and focused on maximizing revenue from the daily payment rate that Medicare provides rather than on the quality of care for dying patients. The daily payment structure of the Medicare hospice benefit, which pays a fixed per diem rate for each day a patient is enrolled, creates a financial incentive to enroll patients for as long as possible. A patient enrolled for 180 days generates 3 times the revenue of a patient enrolled for 60 days, regardless of the actual cost of providing care. Some for-profit providers have responded to this incentive by enrolling patients with diagnoses that are technically eligible for hospice, but that do not necessarily involve the kind of active dying process that the hospice philosophy was designed to support. Dementia, heart failure, and other progressive conditions that can be difficult to prognose precisely have been used to justify long hospice enrollments that have attracted regulatory scrutiny. The commercialization of hospice care is one of the most significant ways in which the practice has diverged from the philosophy that produced it. The Connecticut Hospice was founded on a set of principles about how dying people deserved to be treated, with honesty about their prognosis, with adequate pain management, with emotional and spiritual support, with their family as a central part of the care team. A for-profit hospice chain that enrolls patients with uncertain prognoses to maximize per diem payments and that provides minimal visits from the interdisciplinary team that the philosophy requires is not practicing hospice in the sense that Cicely Saunders or Florence Wald intended. This tension between the hospice ideal and the hospice business has been present to some degree since the benefit was established, and it has intensified as for-profit providers have grown to dominate the industry. It raises fundamental questions about whether the Medicare hospice benefit, as it currently operates, is delivering the quality of dying experience that its architects intended. What it has undeniably delivered is access. Before 1982, hospice care was available only to those who could pay out of pocket or who happened to live near one of the handful of charitable hospice programs in the country. Today, hospice care is available to Medicare beneficiaries nationwide, a benefit that has transformed the dying experience for millions of elderly Americans who could not otherwise have afforded it. The woman dying of cancer in Cincinnati in 1975 had no access to hospice care that was financially viable for her family. A woman in the same situation today, in 2025, has access to a Medicare-covered hospice program that can provide nursing visits, pain management, home health aid support, social work services, chaplaincy, and bereavement support for her family. The difference between those two situations is real and significant, whatever the imperfections of the current program. Whether the current program, with its for-profit providers and its enrollment controversies and its late enrollment patterns, is delivering the quality of care that the benefits architects intended is a legitimate question that is actively being investigated and debated. The answer matters for the millions of Americans who will die in the coming years and who will depend on hospice care, or some evolved version of it, to support them through the dying process. The history of hospice care in America is the history of a philosophical revolution in how a society thinks about dying, translated imperfectly but meaningfully into a federal benefit that has changed the dying experience for millions of people. The revolution began with a British physician who believed that dying people deserve better than what the medical system was providing them, was carried to America by nurses and physicians who saw what was possible, was made financially accessible by a federal benefit that was added for cost-saving reasons as much as for philosophical ones, and has been both preserved and compromised by the commercialization that followed. The woman dying of cancer in Cincinnati in 1975 deserved what was available in New Haven, but not in Cincinnati, available in Britain, but not in most of America. Care designed for dying rather than for the failure to cure. She did not get it because the system had not yet found a way to make it available to her. Her counterpart today has access to it. Whether she receives it as it was intended to be provided depends on the quality of the specific provider she encounters, on the timing of her referral, and on the integrity of a system that has been shaped as much by economic incentives as by the philosophical commitments that produced it. That is the history. The revolution in dying is real. Its full realization is still incomplete. Subscribe if this kind of history is what you are here for. There is a great deal more of it ahead. To understand what the hospice movement was reacting against, you need to spend more time in the specific institutional reality of dying in a mid-20th century American hospital. Because the description of inadequate pain management and exclusion of family members, while accurate, does not fully convey what it actually felt like to be dying, or to be the family of someone who was dying in that system. The typical trajectory of a dying person in 1965 America began with a diagnosis that was often delivered without adequate context or support. A physician who determined that a patient's cancer was incurable would typically document this in the medical chart without necessarily communicating it clearly to the patient or family. The language used was often indirect. The tumor is not responding to treatment. We are running out of options. It may be time to consider comfort measures. These phrases communicated the prognosis to medical personnel who understood the code. They did not necessarily communicate it clearly to patients and families who had not been trained to decode medical language. The patient who understood, or partially understood, that they were dying often had no one in the hospital system to talk to about this. The physician's role was defined as clinical, focused on diagnosis and treatment, not on the emotional and existential dimensions of dying. Nurses, who spent the most time with patients, were often trained to maintain professional distance from the emotional content of their patients' experiences, partly as a self-protective mechanism in a role that involved regular confrontation with death and dying. The hospital chaplain might be available, but many patients and families did not think to request this resource, and it was not routinely offered. The physical environment of the hospital was not designed for dying. Acute care hospitals were designed for the temporary accommodation of patients who were expected to recover and leave. The rooms were functional rather than comfortable, oriented toward clinical access rather than human comfort. The lighting was institutional. The food was institutional. The schedule was institutional. Meals at fixed times, medications at fixed times, vital signs checks that interrupted sleep throughout the night. A patient who was dying and who needed quiet and rest received the same institutional schedule as a patient who was recovering from surgery and whose vital signs genuinely needed monitoring. The pain management problem was not simply a matter of physician attitude, though attitude was a significant factor. It was also a matter of pharmacological practice and of the regulatory environment governing opiate prescribing. Physicians who prescribed opiates for dying patients in quantities sufficient to provide genuine pain control were prescribing quantities that, in a patient who was not dying, would have been considered excessive and potentially addictive. The regulatory framework for opiate prescribing and the professional culture around opiate use that the framework had shaped made physicians cautious about prescribing what dying patients actually needed. The pharmacological principle that adequate pain control required staying ahead of the pain, administering opiates on a regular schedule rather than waiting for the patient to report pain and then responding, was not widely understood or practiced. The standard approach was to administer analgesics as needed, meaning when the patient reported pain that had already reached a level requiring medication. This approach meant that dying patients regularly experienced breakthrough pain while waiting for medication to be administered and to take effect, a cycle of pain and relief and pain that was not necessary but that the system's practices perpetuated. Cicely Saunders had understood this problem clearly. Her approach to pain management at St. Christopher's was built around regular administration of adequate opiates to maintain a state in which pain was not experienced rather than a state in which pain was periodically relieved. The difference in patient experience between these two approaches was dramatic. Patients in the Saunders model could engage with their families, could have conversations, could make decisions, could do whatever they wanted to do with their remaining time because they were not in pain. Patients in the standard American hospital model spent significant portions of their final weeks in pain that was inadequately managed, unable to engage with their families or with anything else. The family exclusion problem was another dimension of the hospital's institutional orientation. Hospitals had visiting hours because the management of a ward of acutely ill patients required periods of quiet and rest that were disrupted by family visits. These visiting hours were applied uniformly, including to dying patients who had different needs from patients recovering from acute illness. A patient who was actively dying, who had days or hours remaining, might have visiting hours restricted to 2 hours in the afternoon and 2 hours in the evening, separating them from their family for most of their final hours. The argument for restricting visiting hours was that the family's presence disturbed the patient's rest. In some cases, this was true. In many cases, the family's presence was what the patient wanted above all else, and the institutional policy was serving the hospital's convenience rather than the patient's need. The hospice model reversed these priorities. The patient's home, or a home-like residential facility, replaced the hospital as the setting for care. Family members were not visitors with restricted hours. They were partners in care, trained and supported by the hospice team to participate in the physical and emotional care of the dying person. The hospice nurse who visited the home was supporting the family as much as the patient, teaching family members how to manage medications, how to provide physical comfort, how to be present with someone who was dying without being overwhelmed by the experience. The bereavement support that hospice provided to families after the patient's death was another element of the model that the hospital system had no equivalent of. When a patient died in a hospital, the family received the news, said goodbye, and left. The hospital's relationship with the family was over. The hospice model maintained the relationship with the family through the grief that followed the death, with bereavement counselors making contact at intervals in the months after the death, assessing how the family was managing and providing support or referrals when needed. This comprehensive model, encompassing the patient's physical, emotional, and spiritual needs, and the family's parallel needs through the dying process and into bereavement, was what the hospice movement was selling to a medical system that had never thought about dying this way. The difficulty was not convincing people that the model was better. The research confirmed that it was better, by almost every measure that mattered to patients and families. The difficulty was getting the insurance system to pay for it. The Medicare hospice benefits establishment in 1982 was the moment when the insurance system agreed to pay, but the conditions attached to that agreement have shaped the practice of hospice care ever since in ways that have both facilitated and constrained the model's realization. The requirement that patients elect hospice care, explicitly choosing it over curative treatment, was the most philosophically challenging aspect of the benefits design. The election requirement was designed to ensure that hospice was used by patients who had genuinely accepted that they were dying and who wanted palliative care rather than continued attempts at cure. In practice, the election requirement created a barrier because many patients and families were not psychologically ready to make a formal declaration of accepting death, even when they understood intellectually that cure was not possible. The cultural dimension of this barrier varies significantly across different communities. American medical culture in the 1980s and 1990s placed strong emphasis on fighting disease and not giving up, and the language of hospice, with its explicit acceptance of death, ran directly against this cultural grain. Families who wanted to do everything for their dying relative found hospice's philosophy uncomfortably passive, even when the act of doing everything they preferred was producing suffering rather than benefit. These cultural attitudes have shifted significantly since 1982, partly as a result of the hospice movement's own advocacy, and partly as a result of broader cultural conversations about death and dying. The publication of Elizabeth Kubler-Ross's On Death and Dying in 1969 was enormously influential in changing how Americans thought about dying, introducing concepts like the stages of grief and the importance of honest communication with dying patients that became widely accepted in subsequent decades. Atul Gawande's Being Mortal, published in 2014, reached a broad audience with a similar message about the inadequacy of aggressive medical treatment for dying patients and the value of the hospice approach. These cultural shifts have been reflected in increased hospice utilization. In 1985, the first full year of the Medicare hospice benefits operation, approximately 158,000 Medicare beneficiaries used the benefit. By 2020, that number had grown to approximately 1.7 million. The program that served a small fraction of dying elderly Americans in its first years of operation now serves a majority of Medicare beneficiaries who die of cancer and a substantial minority of those who die of other conditions. The growth in utilization reflects both the increased awareness of hospice as an option and the cultural shifts that have made the conversation about dying more accessible. It also reflects the increasingly aggressive marketing of hospice services by the for-profit providers who have come to dominate the industry, a marketing orientation that has raised quality concerns as well as utilization. The quality concerns are significant and well documented. The HHS Office of Inspector General has issued multiple reports finding that a substantial proportion of hospice providers are failing to provide the full range of services that the Medicare hospice benefit is supposed to include, that patients with complex symptoms are not receiving adequate medical attention, that staff levels are insufficient to provide the interdisciplinary care that the model requires, and that some providers are enrolling patients who do not meet the hospice criteria in order to maximize revenue. The geographic variation in hospice quality is striking. In some regions of the country, hospice care is consistently high quality, provided by experienced organizations with adequate staffing and strong clinical oversight. In other regions, particularly in areas where the market is dominated by newer for-profit providers, quality is considerably more variable and complaints about inadequate care are more common. The patient who elects the Medicare hospice benefit today is electing a benefit whose quality depends significantly on which provider is available in their area and which provider their physician recommends. This variation is not disclosed to patients at the time of election. There is no public quality rating system for hospice providers equivalent to the nursing home rating system that Medicare publishes. Patients and families who want to evaluate the quality of available hospice providers in their area have limited tools for doing so. The regulatory response to hospice quality concerns has been slow and limited. CMS, which administers the Medicare hospice benefit, has issued compliance guidance, conducted audits, and in some cases revoked the Medicare certification of providers found to be systematically non-compliant. But the enforcement capacity relative to the size of the industry is limited, and the sanctions available are not always sufficient to deter behavior that is financially rewarding even with the risk of enforcement action. The fundamental tension in the current hospice system is between the hospice philosophy, which is oriented toward the quality of the patient's dying experience, and the hospice business, which is oriented toward the financial sustainability of the provider organization. In the ideal case, these orientations are compatible. A provider that delivers high-quality hospice care attracts and retains patients, building a reputation that sustains the business. In the real world, the daily payment structure of the Medicare benefit, the absence of robust quality transparency, and the competitive pressures of a crowded market have in many cases produced a race to the minimum rather than a race to the top in terms of service intensity and quality. The woman dying of cancer in Cincinnati, who did not have access to hospice care in 1975, deserved what St. Christopher's Hospice was providing in London and what the Connecticut Hospice was beginning to provide in New Haven. She did not get it because the system had not found a way to make it available to her. Her counterpart today has access to hospice care, but the hospice care she receives may or may not resemble what Cicely Saunders and Florence Wald envisioned. It may be provided by an experienced, well-staffed organization that genuinely understands and practices the hospice philosophy. It may be provided by a for-profit chain that enrolled her to generate daily payment revenue and that provides adequate but not exceptional care. The difference between these two experiences is significant, and the current system does not reliably distinguish between them for patients trying to make an informed choice. This is the current state of hospice care in America. A benefit that has transformed the dying experience for millions of elderly Americans, that has made quality palliative care financially accessible in ways that were impossible before 1982, and that is being delivered with significant variation in quality by an industry that has been shaped as much by economic incentives as by the philosophical commitments that created it. The history of how we got here, from the hospital death of 1975 to the Medicare hospice benefit of 1982 to the for-profit hospice industry of 2025, is the history of how a philosophical revolution in thinking about dying collided with the economic and bureaucratic realities of the American healthcare system, and of what survived that collision and what did not. What survived is access, the ability of elderly Americans to choose to die at home with professional support for their physical, emotional, and spiritual needs is real and significant. What has been compromised is consistency. The experience of dying under hospice care varies enormously depending on which provider is available and which is selected, a variation that the patient at the most vulnerable moment of their life is poorly positioned to navigate. From the Cincinnati woman in 1975 who had no access to what she needed, to the 1.7 million Medicare beneficiaries who used hospice in 2020, to the ongoing effort to ensure that the care they receive matches the philosophy that made it possible. That is the history of hospice care in America, and the work of realizing it fully is not finished. Subscribe if this kind of history is what you are here for. There is a great deal more of it ahead. There is a dimension of this history that connects the hospice story to the broader story of how America thinks about death, and it is a dimension that deserves careful attention, because it is both culturally important and politically contentious. The hospice philosophy is built on an acceptance of death as a natural part of life, and on the belief that a good death, one that is peaceful, that is consistent with the dying person's values and wishes, that occurs in the presence of loved ones, is a legitimate goal for the healthcare system to pursue. This philosophy is not universally shared in American culture, which has a complicated relationship with death that combines deep anxiety, aggressive avoidance, and the technological optimism of a medical culture that has grown accustomed to treating conditions that were previously fatal. The tension between the hospice philosophy of acceptance and the medical culture of treatment finds its most acute expression in the conversations that occur when a patient with a serious illness is first referred to hospice. These conversations are difficult for everyone involved. The physician who refers a patient to hospice is in some sense acknowledging that medicine has reached its limits. The patient and family who accept the referral are accepting that the dying process has begun. These acknowledgments are psychologically difficult in a culture that has normalized aggressive treatment and that tends to treat acceptance of death as giving up. The difficulty of these conversations is one of the reasons that hospice enrollment occurs so late in the dying process. Physicians who are uncomfortable discussing death and dying are unlikely to initiate the conversation early enough for the patient and family to benefit fully from hospice care. Families who are not ready to acknowledge that their loved one is dying will not hear the suggestion of hospice as an option. And patients themselves, who have been treated for years with the implicit message that there is always another treatment to try, may not be psychologically prepared to elect a benefit whose defining feature is the acceptance that there is not. The work of changing this is partly cultural and partly structural. The cultural change requires normalizing conversations about death and dying in ways that American culture has historically avoided. Advanced care planning, which involves documenting one's preferences for end-of-life care before a crisis makes those preferences impossible to express, has been promoted by hospice advocates, by palliative care physicians, and by public health campaigns as a way of reducing the frequency of aggressive and unwanted treatment at the end of life. The Physician Orders for Life-Sustaining Treatment form, known as PLST, provides a mechanism for translating advanced care preferences into specific medical orders that can be followed by emergency responders and hospital staff. The form has been adopted in most states and has reduced the frequency of unwanted resuscitation and other aggressive interventions. For patients who have expressed a preference for comfort-focused care, these tools have helped. Studies of patients who completed advanced care planning documents consistently find that they are more likely to receive care consistent with their preferences, more likely to die in the setting they prefer, and less likely to receive aggressive interventions they would not have wanted. The family members of these patients also report better outcomes in terms of their own grief and sense that their loved one died well. But the tools reach only the patients and families who complete them, and completion rates remain far below what would be necessary to significantly shift the overall pattern of end-of-life care in America. The patients most likely to complete advanced care planning documents are those who are educated, who have engaged with the healthcare system proactively, and who have the social support to navigate conversations about dying with their families. The patients least likely to complete them are those who face the greatest barriers to healthcare access, who have the most difficulty engaging with a complex bureaucratic healthcare system, and who are disproportionately concentrated in the communities that have historically received the worst care. The racial dimension of end-of-life care disparities is significant and well documented. Black Americans are significantly less likely than white Americans to use hospice care, more likely to die in the hospital, more likely to receive aggressive treatment at the end of life, and less likely to have completed advanced care planning documents. These disparities are not simply a product of preference. Research that has attempted to identify whether they reflect different cultural attitudes toward death and dying or different access to and trust in the healthcare system has found that distrust of the healthcare system is a significant factor. The history of how the American healthcare system has treated Black Americans, including the Tuskegee syphilis study, the segregation of hospitals, the exclusion of Black workers from early Medicare coverage, and the systematic undertreatment of Black patients' pain, provides a rational basis for distrust of that system's intentions in recommending hospice care. A healthcare system that tells a Black patient it is time to stop curative treatment and focus on comfort care may be making the right recommendation. It is also a healthcare system with a history that provides reasons for skepticism about whether its recommendations are in the patient's interest. Building the trust that would enable higher hospice utilization in communities that have historically been underserved by and mistreated by the healthcare system requires more than better marketing of hospice services. It requires the long-term work of building genuine relationships between hospice providers and communities, of training hospice staff who reflect the diversity of the communities they serve, and of demonstrating through practice that the hospice recommendation is being made in the patient's interest rather than in the system's interest. Some hospice organizations are doing this work. The growth of hospice programs specifically designed to serve African American, Latino, and Asian communities, with staff who share the language and cultural background of the patients they serve, has produced improvements in hospice access in some areas. But the work is slow, the resources devoted to it are limited, and the disparities persist at a scale that indicates the current efforts are insufficient. The palliative care movement, which is related to but distinct from hospice care, has developed in part as a response to the limitations of the hospice model. Palliative care is the provision of symptom management and emotional support alongside curative treatment, rather than as an alternative to it. A patient with serious cancer who is receiving chemotherapy can also receive palliative care support for the symptoms produced by the cancer and the treatment: nausea, pain, fatigue, anxiety, the practical challenges of living with serious illness. The evidence that early palliative care alongside curative treatment produces better outcomes than curative treatment alone has been accumulating since a landmark 2010 study of patients with metastatic lung cancer found that those who received early palliative care had better quality of life, better symptom management, and actually lived significantly longer than those who received curative treatment alone. The counterintuitive finding that accepting comfort-focused support alongside curative treatment produced longer survival was attributed to the improved quality of life, enabling patients to tolerate treatment better, and to the reduced use of aggressive interventions near the end of life that the palliative care team helped patients avoid. The palliative care movement has grown substantially since this research was published, with hospital-based palliative care programs now present in most major academic medical centers and growing in community hospitals. But access to palliative care remains uneven, with significant disparities across geography, hospital type, and patient population. The patients who most need palliative care support, those with serious illness who are dealing with complex symptom burdens and who are facing difficult decisions about treatment, are not consistently able to access it. The connection between the palliative care movement and the hospice movement is both philosophical and practical. Both are oriented toward the quality of the patient's experience rather than the extension of its duration. Both emphasize the importance of the patient's own values and preferences in guiding care decisions, and both face the same fundamental challenge in the American healthcare system: a reimbursement structure that pays for procedures and treatments more readily than for the kind of intensive human support that is central to both hospice and palliative care. A surgeon who performs an operation is reimbursed at a level that reflects the technical complexity of the procedure. A palliative care physician who spends 2 hours with a patient and family discussing goals of care, helping them understand the implications of different treatment options and supporting them through an emotionally devastating conversation, is reimbursed at a fraction of that level. The disproportion in payment reflects the broader structure of American medical reimbursement, which has historically valued technical intervention over the cognitive and emotional work of caring for seriously ill patients. This structural disproportion has been a persistent obstacle to the development of palliative care and hospice as fully resourced, fully integrated components of the American healthcare system. Reforming it requires either changing the reimbursement structure, which is politically difficult because the beneficiaries of the current structure are organized and powerful, or finding other ways to fund the human-intensive work of supporting dying people, which has not been systematically achieved. The woman dying of cancer in Cincinnati in 1975 deserved a healthcare system that knew how to support dying people rather than simply treating them. She did not get it. Her counterpart in 2025 has access to a Medicare hospice benefit that has transformed the dying experience for millions of Americans. Whether that benefit, as it is currently implemented, delivers the full quality of support that the hospice philosophy promises depends on which provider she encounters, how early in the dying process she is referred, and whether the cultural and racial barriers to honest conversation about dying have been adequately addressed in her specific situation. The history of hospice care in America is the history of a philosophical revolution that is still being realized, imperfectly, in the face of economic and cultural obstacles that the revolution's founders could not fully anticipate. From the Cincinnati woman in 1975 who needed what was available in London but not in Ohio, to the 1.7 million Medicare beneficiaries who used hospice in 2020, to the for-profit providers and the quality variation and the late enrollment and the racial disparities that characterize the program today. The revolution happened. The full realization of what it promised is still being worked out, one dying person at a time. Subscribe if this kind of history is what you are here for. There is a great deal more of it ahead. One final thread connects this history to the question of what comes next, and it is a thread that is becoming more urgent as the baby boom generation moves through the years when the probability of needing end-of-life care increases most rapidly. The 73 million Americans born between 1946 and 1964 are now between 61 and 79 years old. Over the next 2 decades, the vast majority of them will face the dying process, either their own or that of their parents and partners. The scale of the dying that is coming is unprecedented in American history, and the systems that are supposed to support it are not fully prepared for it. The hospice workforce is already under pressure. Hospice nurses, social workers, chaplains, and home health aides are in short supply relative to the current demand for their services, and the demand will increase substantially as the baby boom generation ages into the highest risk years. The training pipeline for hospice professionals does not currently produce enough graduates to meet the projected need. Wages for hospice workers, particularly home health aides who provide the most labor-intensive care, are not sufficient to attract and retain an adequate workforce in a competitive labor market. The geographic distribution of hospice services is uneven, with rural areas particularly underserved. A dying person in a rural area may have limited access to in-home hospice visits because the distances involved make it economically impractical for providers to serve widely dispersed patients. Telehealth has begun to fill some of this gap, allowing hospice clinicians to provide some support remotely, but the human connection that is central to the hospice philosophy is not fully replicable through a video screen. The financial sustainability of the Medicare hospice benefit is also under pressure. The per diem payment rates that Medicare pays hospice providers have not kept pace with the cost of providing care, particularly in the period since 2020 when inflation in healthcare labor costs has been significant. Providers who are committed to providing high-quality care are finding it increasingly difficult to do so within the payment rates that Medicare provides, while providers who are willing to minimize services to control costs can remain financially viable at the expense of care quality. These pressures are producing a two-tier hospice system in some markets. High-quality providers who serve patients who can supplement Medicare payments with private resources or who have access to philanthropically supported programs, and lower-quality providers who serve the majority of patients within Medicare's payment rates at service levels that are adequate but not ideal. Addressing these pressures requires policy changes that have not yet occurred. Increasing Medicare payment rates for hospice care, improving the public transparency of hospice quality data, strengthening regulatory enforcement against providers who fail to meet quality standards, and investing in the training and compensation of the hospice workforce are all necessary components of a system that can meet the scale of dying that is coming. The political will to make these investments exists in some measure, driven by the growing recognition that end-of-life care is a major component of healthcare spending that is not being managed effectively, and by the personal experience of legislators and their constituents with the dying of aging parents and partners. But the competing priorities of a healthcare system that is also dealing with the costs of chronic disease management, mental health care, and the aftermath of the COVID-19 pandemic mean that the investment in hospice and palliative care is competing with other urgent needs. The woman dying of cancer in Cincinnati in 1975 could not have imagined that 47 years later, a federal benefit would exist that paid for professional support through the dying process. She would have wanted it. She deserved it. She did not have it because the political and medical systems of her time had not yet found a way to provide it. The people who will need hospice care over the next 2 decades deserve a system that delivers what the Medicare hospice benefit promises. Building that system requires the same combination of documentation, advocacy, and political will that built the benefit in the first place, applied now to the task of ensuring that the benefit delivers on its promise. That is where this history leaves us. Not at the beginning, where there was no federal coverage for dying at home with professional support, not at the ideal, where every dying person receives the full quality of hospice care that the philosophy envisions, somewhere in between, with a benefit that has transformed the dying experience for millions of Americans and that has not yet fully realized what it was designed to provide. From the Cincinnati woman in 1975 to the 1.7 million hospice users of 2020 to the baby boom generation now approaching the years of greatest need. The history is real. The achievement is real. The work is not finished. Subscribe if this kind of history is what you are here for. There is more ahead. There is one more observation that this history demands before we close, and it is an observation about what the hospice story tells us about how medical and social change actually happens in America. The hospice movement began not with a federal policy but with a philosophical conviction held by a small number of people who believed that dying people deserved better than what the medical system was providing. Cicely Saunders in London and Florence Wald in New Haven did not begin by lobbying Congress or drafting legislation. They began by building something, by demonstrating through practice that a better approach to dying was possible, by gathering evidence that the better approach produced better outcomes, and by training the people who would carry the approach into the wider medical system. This bottom-up process, from philosophical conviction to practical demonstration, to research evidence to policy change, is how many of the most important advances in American healthcare have occurred. The development of safer surgical techniques, the understanding of infection and sterility, the recognition of the role of lifestyle factors in chronic disease, the development of evidence-based medicine itself. None of these began with federal policy. They began with individuals or small groups who had a different understanding of what was possible and who built the evidence that eventually changed practice and policy. The hospice movement built its evidence over roughly 15 years before the Medicare benefit was established. The Connecticut hospice opened in 1974. The Medicare benefit was established in 1982. 8 years of demonstration, evaluation, and advocacy produced a federal policy change that transformed access to hospice care for elderly Americans. This timeline, 8 years from demonstration to policy change, is fast by the standards of American health policy. It reflects the specific political moment of 1982, when cost savings provided a compelling argument for adding a benefit that might otherwise have faced more resistance, and the specific quality of the evidence that hospice advocates had assembled. Understanding how the hospice movement succeeded in translating a philosophical vision into federal policy is useful for understanding what would be required to address the remaining limitations of the current system. The problems are documented, the solutions are available. The evidence that better hospice quality produces better patient outcomes is as strong as the evidence that hospice care produces better outcomes than hospitalization was in 1982. What is missing is the political moment. The hospice benefit of 1982 was added because the Reagan administration was looking for ways to reduce Medicare spending, and hospice appeared to offer savings. The case for improving hospice quality, for investing in the hospice workforce, for eliminating the enrollment barriers that cause late referral, and for addressing the racial disparities in hospice access does not have an obvious analog to the cost savings argument that worked in 1982. Building the political case for these improvements requires connecting the quality of hospice care to outcomes that policymakers care about. Medicare spending on aggressive end-of-life care that patients do not want, hospital admissions in the final weeks of life that the hospice benefit was supposed to reduce, patient and family satisfaction with end-of-life care that falls short of what the benefit promises. These connections exist. The research supports them. The political work of translating research into policy remains to be done by the advocates, researchers, and policymakers who understand what is at stake and are committed to improving it. The Cincinnati woman who died in 1975 is part of that work. Her experience, and the experience of the millions of Americans who died in similar circumstances before the hospice benefit existed, is the historical foundation of the argument that dying people deserve professional support through the dying process. The argument won in 1982. It has not yet fully won in the sense of ensuring that every dying person receives the quality of care that the benefit promises. The work of ensuring that continues. The history is why it matters. From the hospital death of 1975 to the Medicare benefit of 1982 to the 1.7 million hospice users of 2020 to the quality and access challenges of 2025. From Cicely Saunders in London to Florence Wald in New Haven to the hospice nurse visiting the home of a dying person in Cincinnati today. That is the history of hospice care in America, and the full realization of what it promises is still being worked toward. Subscribe if you want to keep following this kind of history. There is more ahead.